Much for the invitation. Actually, we have a little bit different definition of the black swan, but try to do our best. Where this positive resection line thing depends on where it is, what is the extent, the depths, how many cells are in this resection line, and what was the cell type, and what sort of surgery was done before. And what is very important again from the aftercare, the patient and the tumor. That's a non-existing bird, the black swan, like the Griff, with the big difference that it's existing. And we know it from the Juvenalis, from the Latin author, and even that comes as a surprise and has a major effect. However, on this positive margin issue, there are different opinions and ambiguity on the prognostic implication of the margin involvement when we are talking about the R1 resection. The R2 is obviously a very black thing. Some studies suggest a negative impact, others have different opinion, and it's more divergent, the opinion on adjuvant therapy. It's absolutely unclear. The series are small, single institutions, and there is only one exception from the Journal of Thoracic Oncology 2 years ago. I will come back later. Anyway, the R1 resection is a bad news, but how bad it is really? The positive resection line report varies between 1 and 17%. The American data is around 6%. However, in the reports there are limitations, many bias, retrospectivity. We have no data on the details of the local practices. The anatomic site extension of margin involvement have many serious implications. And the carcinoma in situ versus extensive issue is very important again. In a retrospective, the post-operative actions were mainly radiotherapy after an R1 resection. However, after the millennium, the radiotherapy was replaced by the chemotherapy in many centers. The big series report that there is a real implication on the survival in the early stages, 1A, 1B, and partially in stage 2, but when we are talking about the stage 3, the negative influence, negative impact is not so serious and quite unclear in some cases. Anyway, in the in situ versus invasive R1, it's 2 pieces of cake, and it's less than 1% when the stage 1 cases are involved in this unlucky situation. The residual disease in the resection line usually follows squamous cell carcinoma, and when the mediastinum is on the spot, then actually all of the possible organs can be involved. And if the N1 disease is ruled out, then the postoperative adjuvant chemoirradiation offers a good hope. With the lymph nodes, again, there is an ongoing question or the debate, what is R1 really? Because if the highest lymph node is positive, then it's not RO, but R unclarified. The chest wall and the diaphragm, we just heard about how important the diaphragm is in inflammatory cases. Yes, in the cancer issue, it's the same. We see stage migration from T3 to T4 in the AST/NM, and that's a bad prognosis. But on the other side, in the chest wall, if the margin is positive, then the adjuvant chemoradiation is recommended. The pleural fluid positivity is per se a priori R1 situation. However, the survivals in comparing 3B and even 3A in some series, and pleural fluid positivity are nearly equal. So that's not the end of the story. And if the cells and other factors are were taken into consideration, then 2 or 3 distinctive groups can be differentiated, and the prognosis and the postoperative adjuvant therapy is recommended in those cases. What to do if the margin was positive? Obviously, there is a negative impact on the survival, so the RO is better than R1, no question about that. However, the overall survival differs if concomitant radiochemotherapy or radiotherapy followed or in a sequential form. So in some series, the postoperative irradiation after R1 resection makes a good impact on the survival. However, the distant metastasis will remain the same. Coming back again to this huge American series, 100,025 cases, and 4.7 of them were positive margin. And what they saw, if radiotherapy and chemotherapy were applied in nearly equal cases postoperatively, if that was an R1 case. How to proceed if resection can be done? Yes, the bronchoplasty or resection is the second option. The survival impact of incomplete resection is a sort of stage migration. So the R1 stage 1 case survival is comparable to an R0 stage 2 case, and this goes down in all of the spectrum. An R1 PT1 disease has a survival curve overlapping with the same R0, but with T3 disease, and is speaking for itself. The chemotherapy, when it was applied, then offered better survival, irrespective of stage, but the radiotherapy, especially in stage 1, it made a significantly worse survival than the nothing. In stage 2 and 3, no significant impact on patients. It's a quite surprising finding. In the stage 2 and the stage 3 curves are proving that observation. Yes, if there were no adjuvant therapy in stage 1, the radiotherapy survival was definitely significantly worse, and if chemoradiation was applied, then it was nearly the same when no adjuvant therapy was applied. Surprising observations. Anyway, there is an obvious strong association between the neoadjuvant therapy and the R1, and the radiotherapy, the neoadjuvant radiotherapy, increases the likelihood of R1 resection. The sublobar resection and the preoperative neoadjuvant therapies, these are the two risk increasers. No clinical characteristics and the risk for R1 are there. It's a good quality indicator. The racial minorities, the and downs, are at higher risk, obviously, plus the patient demographics influences the results. There are missing data really on the impact of the individual caseload, the experience of the surgeon, the caseload, the open versus Watts procedures, and we have to admit that the quality of the pathologist is a player, plus we don't know what's going on the pathological lab in the staple line issue. So what to do if there is an R1? Irrespective of stage, postoperative adjuvant chemotherapy reduces mortality risk, that's clear, but contrary to the current recommendations, the postoperative adjuvant radiation has a negative impact, definitely. Maybe different best adjuvant therapy options for different subsets of patients are to be applied. Not only the cells are posing a danger, however, with oncogenic mutations in the resected bronchial margins, they have a negative prognostic value. Yes, the positive margin is a real black swan event, several consequences. The damage control, what should we do? Postoperative chemotherapy, the question of the targeting therapy and immunotherapy is for the coming years. And if we get a dark report, then we, from the pathological department, we have to ask what is the extent of the positivity, what is the cell type and the stage, because in stage 1, re-resection would be recommended. In any other further consideration is needed, the condition of the patient, and we have to decide what improves real survival, re-resection, or the adjuvant chemotherapy. So the take-home message is that there is no general answer. It depends on the stage and the cell type, the chemosensitivity, whether there is a room for target or immunotherapy, and of course, I would start with that, the patient around the R1 resection line.